Across many traditional Indian joint families, the 40-day period of japa, or postpartum confinement, follows a predictable pattern. The elder women of the household take over the traditional cooking and newborn care, and the husband is encouraged to step back and return to his normal work routine. Culturally, this physical separation is treated as normal. Clinically, leaving the mother isolated behind a closed door to manage her trauma is a profound mistake. The support of grandmothers is invaluable for keeping the newborn fed and maintaining the household, but the mother's body has just executed a massive physiological event. While the elders manage the baby, you, the partner, must step in to manage her medical healing. Before we go any further, note the exact type of delivery your partner just experienced. The physical protocols you are about to enforce are highly specific to her anatomy, and the rules for a surgical birth are entirely different from a vaginal birth. You are taking over a specific set of clinical responsibilities. Starting today, you are the primary member of the medical team responsible for her recovery. A cesarean section is major abdominal surgery. The obstetrician slices through 7 layers of tissue, including the fascia. Because internal sutures are incredibly fragile, she cannot lift anything heavier than her newborn for 6 weeks. Excess strain dramatically increases her risk of an incisional hernia. She cannot sit straight up in bed to reach for a crying baby without placing violent pressure on her stitches. You must physically assist her using the log roll technique. Help her roll completely onto her side, drop her legs over the edge of the mattress, and support her upper back so she uses her arm strength to sit up. During the night, you take over all physical logistics. When the newborn wakes, she stays perfectly positioned with her nursing pillows. You lift the baby, check the diaper, hand the baby to her breast, and take the baby back for burping so her core remains protected. You also manage her surgical hygiene. Showering with a fresh incision is terrifying. You must ensure the water hits her back and gently runs down over the incision rather than blasting it directly. Afterward, you must help her gently pat the incision perfectly dry. Trapped moisture in the skin fold above a cesarean scar breeds dangerous bacterial infections. Finally, you enforce her daily mobility. Surgery drastically thickens the blood. To prevent a deep vein thrombosis, a deadly blood clot in the leg, you must offer your arm and ensure she walks slowly for 5 to 10 minutes every few hours, every single day. By taking over every action that requires her to flex her abdominal muscles, you operate as her physical core. You are actively preventing a second major surgery and protecting her from lethal blood clots. For mothers who deliver vaginally, the cultural assumption is a rapid return to household duties because there is no abdominal scar. This ignores the intense physical trauma, swelling, and suturing inflicted on her perineum and pelvic floor. Look at this schematic. This is the safe bathroom station you must build before she even enters. You must completely ban the use of traditional squatting toilets or harsh washing buckets. Squatting places tearing pressure on fresh stitches. Ensure she uses a Western commode with maternity pads stationed within arm's reach so she never bends down. Next to the commode, you place her peri-bottle. Urinating with fresh stitches causes a severe, stinging burn. You must fill a sterile spray bottle with lukewarm water for every single bathroom trip. She will spray a continuous stream over her perineum while urinating to dilute the acidic urine and eliminate the pain. You also take charge of lochia monitoring. We have mapped the equation on screen. If she soaks through more than 1 large maternity pad per hour for 2 consecutive hours, her uterine muscle is failing to contract. This is a dangerous secondary postpartum hemorrhage. You must also minimize her standing time. Gravity prevents a stretched pelvic hammock from healing.
If she stands to rock a baby, downward pressure delays recovery. Take the baby whenever it is not actively feeding so she can lie flat. Removing gravitational strain from her pelvis and tracking pad usage makes you her safety net against a future uterine prolapse or silent hemorrhage. Look at this dietary comparison. Elders provide the mother with dense, comforting sweets like panjiri or dinkladus. These are excellent for vital energy. However, these heavy foods severely lack dietary fiber. When you combine that density with the massive fluid drain required to produce breast milk, you create an environment for severe digestive backup. The mechanical risk here is severe. Constipation forces the mother to physically strain, which can violently tear open the fresh abdominal or perineal stitches we just worked so hard to protect. You are the hydration manager. She must consume a minimum of 3 liters of water every single day. Because a breastfeeding mother is pinned under a feeding baby, you must physically hand her a glass of water every single time the baby latches. You also advocate for her protein intake. To generate the collagen needed to rebuild severed fascia or torn perineal skin, she needs high-quality protein. Ensure she receives eggs, lentils, or fresh paneer, or lean meats in every meal. Balancing this dietary pipeline converts traditional energy foods into a safe, functional healing process that protects her stitches. During customary naming ceremonies or when extended family visits, the house becomes loud and chaotic. This environment directly threatens the mother's recovery. You are the absolute gatekeeper of her rest. You enforce boundaries. You greet the guests, you serve the tea, and you protect her closed bedroom door. If she is sleeping, you never wake her up for a visitor. Newborns sleep in scattered 2 to 3 hour bursts, completely destroying the mother's sleep architecture. This level of sleep deprivation is the fastest trigger for severe postpartum anxiety. Expect periods of weeping and overwhelm in the first 2 weeks. This is the baby blues, caused by a massive crash in estrogen and progesterone. However, you must monitor her for the shift into clinical postpartum depression. Watch for specific warning signs: complete detachment from the baby, staring blankly at the wall, unable to perform basic tasks, or any expressed desire to harm herself. A mother inside the fog of exhaustion cannot accurately diagnose her own mental state. You are her objective psychological shield, and you must initiate medical intervention if these signs appear. Finally, you are the clinical observer in the house. If you see any of the following absolute red flags, you bypass all home remedies and contact your doctor or proceed to the obstetric emergency room immediately. Check this clinical dashboard. First, monitor her temperature. If it rises above 100.4 degrees Fahrenheit or 38 degrees Celsius, you are looking at a systemic infection that can rapidly progress to sepsis without immediate intravenous antibiotics. Next, watch the scale for blood loss. Seek urgent care if her vaginal bleeding suddenly turns bright red with clots larger than a golf ball. This indicates a hemorrhage. Now the dashboard shifts to blood pressure. Act instantly if she complains of a severe, unrelenting headache coupled with blurred vision. This is the primary symptom of postpartum preeclampsia, a life-threatening blood pressure spike. Finally, look at the circulatory indicators. If she develops a sudden, sharp pain in her chest, shortness of breath, or a hot, swollen, red area on her calf, take her to the emergency room immediately to rule out a fatal blood clot. Review these steps tonight. Share this video with the elder women so everyone understands and respects your medical authority during this period. Executing this care plan prevents secondary surgeries and ensures her body rebuilds safely. You are her first line of defense against postpartum complications.